So thank you very much, Dr. Rastogi. I'm happy to be here and share with you some new developments in primary hyperoxaluria and new treatments that are available for this. Shown here are my disclosures for a number of companies as with research grants and advisory boards for companies doing work in hyperoxaluria. So I thought I'd start out with a recent case. It's a 55-year-old female. She's native of India, has been living in the United States for a number of decades. She'd had multiple kidney stones, and they had started fairly early in her mid-20s. She required 3 shockwave lithotripsy procedures, 1 ureteroscopy. She had passed 3 to 4 other stones. Most recent was about 4 years before we had seen her in 2013. Of note, she did have a brother who had died at age 10 with kidney stones and kidney failure. Parents had both had 1 kidney stone each, but no kidney failure otherwise in the family, and there was no known consanguinity in the family. So her creatinine had been very normal, so her kidney function had been good in 2014 and 2015, but in 2017, which was about 4 months before we saw her, it had jumped to 1.6, and then the next month it was 2.07, and by October it was 2.5. She'd had a kidney biopsy in early October because of this rising creatinine, which showed evidence of calcium oxalate crystal deposits. She'd had some issues in the time since then with dehydration, an episode of SVT that required a hospitalization, somewhat rocky course there. And by the way, she did mention she took a lot of herbal remedies. So she had a rather peculiar program that wasn't very clear that she was on to try to control her health and kidney stones. These were her labs at the time we saw her in late November. So her creatinine was still relatively high, 2.6, which gave her an estimated GFR of about 20. And by cystatin C, her GFR was also 20. So pretty advanced chronic kidney disease. And her plasma oxalate here was also high initially at 41.7, which is pretty ominous in this disease. Normal for that should be less than 1.5. So both of those would get your attention if you were seeing this person. Her urine studies are shown here, 24-hour urine supersaturation profile. Of note, her urine oxalate here was 170 milligrams, which is a very high number. Normal for that would be less than about 40 or so. And her supersaturation, therefore, for calcium oxalate was very high. This panel here is the metabolites, which might indicate one of the specific kinds of primary hyperoxaluria for glycolate, glycerate, and 4-hydroxyoxyglutarate. Actually, those were all normal on this, so that was one thing that went against the genetic cause. This was her CT study. So she did have a number of stones in both kidneys, and her kidneys themselves looked a little bit scarred, perhaps. But overall, not a ton of kidney stones. We were able to get genetic testing for AGXT through our research consortium, and this did confirm that indeed this is primary hyperoxaluria type 1. She had a homozygous C568 beta A change. So this was diagnostic of type 1 primary hyperoxaluria. Unfortunately, she progressed fairly quickly to end-stage kidney disease by the end of that year and was started on dialysis. And we dialyzed her aggressively 5 to 6 times a week for about 10 months. And then eventually, before the end of that year, she was able to get a kidney and liver transplant and did reasonably well after that. So what is oxalate? That's shown here. So the oxalate's a 2-carbon 4-oxygen molecule. It's negatively charged. The problem with oxalate is, number one, humans have no way to metabolize it. So whatever oxalate that comes into our bodies, either through food or from endogenous metabolism, has to be excreted by the kidneys, and also likes to bind to calcium. So when it's excreted into the urine, it tends to form calcium oxalate crystals shown there. And then if you have enough of this, you can develop kidney stones as well as oxalate nephropathy. These are some of the foods that are high in oxalate. And in fact, all these foods where we get our oxalate in general in plants, it actually exists as calcium oxalate crystals as well in the specific vacuoles inside the plant. Some plants are higher than others. You really need to get a list much more detailed than this if you really want to understand what someone's dietary oxalate intake is, because it's not listed on food labels. But in this case, it was genetic, so it was coming from her own liver. And so she had primary hyperoxaluria. So primary hyperoxaluria, though, on the other hand, is due to overproduction of oxalate in your bodies themselves. And that's shown here that there are currently three known genetic forms of primary hyperoxaluria. Type 1 due to mutations in AGT, type 2 to GRHPR, and type 3 to HOGA. And those different proteins are shown here. In the case of type 1 with AG2 mutations, you have increased backup of glyoxylate, and then this is converted by LDH to oxalate. And in the case of type 2, it's GRHPR. And again, this leads to backup and buildup of glyoxylate, and then this is further metabolized down to oxalate by LDH. Type 3, which is the most recently described form, it's actually not so clear why these patients get hyperoxaluria, because the mutation here really should not lead to anything that we know of that would cause oxalate in the behind that particular enzyme. But there is evidence that this metabolite, 4-hydroxyoxyglutarate, does inhibit GRHPR, which is the type 2 enzyme inside the mitochondria. And presumably this leads to increased glyoxylate, and then that also can then be converted into oxalate. The ancillary tests, so in pH type 1, glycolate tends to be high, in pH 2, glycerate, and then in pH 3, this 4-hydroxyglutamate tends to be high. So this is a diagnostic algorithm of primary hyperoxaluria and what might make you think and test for this further. So in patients with normal kidney function, kidney stones or nephrocalcinosis in childhood would be a tip-off. Recurrent calcium oxalate stones or nephrocalcinosis in an adult like the person that we saw, and especially if there's a family history of primary hyperoxaluria. If that's the case, we definitely want to get urine studies that would include urine oxalate. If it's high, and the cutoff that's generally accepted is over 0.7 millimoles, which would be roughly 70 milligrams per day. If it's a young child, you have to correct for body surface area. Then you might want to repeat that testing just to confirm it. At that point, the urine metabolites, including the glycolate, glycerate, HOGA would be helpful. And if you do confirm it, at that point, you're going to want to go into genetic testing, which is shown on the next slide. If, on the other hand, the urine metabolites in particular are normal, you really want to think, could there be a secondary cause? And the big things here would be malabsorption, so fat malabsorption, any kind of gastrointestinal disease which might lead to fat malabsorption, and then certain diets. People can be on a very high oxalate and or low calcium diet and get hyperoxaluria just from that. And then sometimes in younger kids, it's harder to rule in, rule out genetic causes just from the lab tests, just because the labs change a lot in the first year or two of life. If the person has chronic kidney disease, meaning a GFR less than 30, it may be more problematic to try to diagnose this, especially when they get closer to dialysis and they don't make enough urine to really accurately measure their oxalate. In that case, supportive things that make you think about pH would be a history of calcium oxalate stones, history of oxalate on a biopsy, either of the kidney or elsewhere, or nephrocalcinosis. In this case, urine oxalate, if they're still making urine, can still be very helpful. It really stays pretty high until very late in chronic kidney disease. But in the plasma oxalate becomes even more helpful here, that I'll show later. But plasma oxalate tends to go up quite high in pH as GFR goes down. And that can often be the quickest thing you can do to rule this in as a possibility or not. And we have as the cutoff for us is really over 20, that in regular chronic kidney disease, you might see plasma oxalates up to 20, but if it gets much more than that, really think about pH. And this is here we were in the last slide. So in general here, if it's either very suggestive or we can't really rule out GI causes, the next step is going to be to do the genetic testing. And typically nowadays we would go ahead and do all 3 genes at once. I mean, you can prioritize this. A lot of labs will do 1 gene at a time based on the urine metabolites, but it's probably easier just to do all 3 genes. It's easy enough now to get panel testing, and there are several commercial firms that are even offering this for free now for pH. So I would probably go that route if there's a strong enough suspicion. And this would, if yes, they find a mutation, then we can make the diagnosis of type 1, type 2, type 3. If they do not have a mutation, really there's not a lot of other diagnostic studies we can do right now. I would say consider enrolling them in a research protocol, which there are a lot of researchers doing work in primary hyperoxaluria. We do think there are probably patients that do have a genetic cause that isn't one of these 3 genes, or maybe there's something more complicated going on, but these are the type of people it would be good to get enrolled in research studies so we can get enough of these type patients to do further studies and see if there is a pH type 4 or pH type 5, that sort of thing. In this particular disease, urine oxalate is really a key prognostic indicator. And this is data here from our Rare Kidney Stone Consortium registry. And it's showing the percent of patients free of end-stage renal failure years after diagnosis, going out to 30 years. And the urine oxalate here is divided by quartiles in our population, so each 25%. So the lower group was less than 1.1. This is millimoles per day. And again, for that, normal is 0.46. Then the next quartile, 1.1 to 1.6, 1.6 to 2.4, and then greater than 2.4. And especially in this high urine oxalate group, that was a very bad prognostic indicator, so over 2.4 millimoles per day. The likelihood of end-stage renal failure by the time you were 30 or 40 was pretty high, over 80%. And the 1.6 to 2.4 group was intermediate. And these people in these upper quartiles here, which were less than 1.6 or less than 1.1, tended to do better, although obviously you're not out of the woods, and some of those people will still go on to end-stage kidney disease. So this was some key evidence that makes this a very good biomarker for clinical studies, and also was important for FDA as far as approving some of these therapies based just on urine oxalate alone. This is some newer data from the registry, looking at it by pH type. And really, again, it highlights the fact of two things. Number one, we know that urine oxalate tends to run higher in pH 1 than pH 2, and then pH 2 is higher than pH 3. And it's not surprising then that the kidney prognosis, so out to age 60, almost 90% of the pH 1 population has traditionally reached end-stage kidney disease. For pH 2, data like 5 years ago in our registry suggested not so many went on to kidney failure, but as time has gone on and we've gotten more patients, it's clear that pH 2, although it's probably not as severe, still a significant proportion will develop kidney failure. And then pH 3, it's rarer, but as this is the newer, newly discovered disease, we're defining more and more cases as we build an experience. So I wouldn't say that you have no risk of end-stage kidney disease. It's low. And then there are some cases being reported, and I think more to come for pH 3. I think we're going to find that it is a risk factor, but it's not going to be the same as pH 1, for example. Key manifestations of this are kidney stones and nephrocalcinosis. So here, if we look at stone events, this is all types of pH together. And it's in general about 0.3 stones per year, which would mean every 3 to 4 years you would pass a kidney stone. Procedures more like every 7 or 8 years. And then stone events total per year, it's one every couple years. And if we look at it cross-sectionally on imaging, this population will have on average 3 to 4 stones at any given time on their imaging. And then nephrocalcinosis, pretty common. So about 30% or 37% will develop nephrocalcinosis, and pretty often this is a harbinger of end-stage kidney disease. And this again is newer data from our registry that we've been pulling together over the last 6 months. And in this case, we're showing pH 3 is in the first column because we're really trying to understand a little better about type 3 pH and how that compares to the other two that we have more experience with. And nephrocalcinosis here is less common in pH 3. So it's not 0 though, so it's 6 or 7% so far, compared to 25% in type 1 and 15% in type 2. The GFR diagnosis does tend to be best in pH 3, so pretty normal in most people, but reduced in pH 1. Plasma oxalate tends to run higher in pH 1, although you have to factor in the kidney function when you're thinking about that. And they do tend to have worse kidney function, which is part of why that's higher. Urine oxalate tends to be highest in pH 1 compared to especially pH 3. Urine calcium really runs quite low in pH type 1. This is fairly characteristic. It's not clear exactly why this is, but in pH 3, it tends to run a little higher. And there are actually a subset of the pH 3 patients that tend to also have some hypercalciuria that we don't completely understand at this point, and they contribute to their active kidney stone disease. And this is a newer graph where we were trying to look at stone events over time, because there had been this impression that pH 3 was mostly a disease of younger kids and went into remission as you got older. But in point of fact, we're finding that stone events, at least in the registry with cross-sectional data, seem to be pretty constant over the lifespan. And this is just showing individual patients with 1 dot per decade, the number of stone events they've had. And it really goes out through the decades. And it's, if anything, more common stones overall in PH3 compared to the other 2 types of PH would be the other take-home message. But in all forms, we do see stones kind of throughout the age spectrum. Probably tapers off in PH1 in particular, because a lot of these people will then have gone on to chronic kidney disease and or end stage. Nephrocalcinosis, when we've looked at this in the total PH population, this is an ominous harbinger. And in general, we do see evidence of nephrocalcinosis before patients go on to end-stage renal failure. And it really increases your risk quite a bit, especially over the next few years that you're going to have issues with your kidney function. PH type 1 is interesting, the AGT enzyme. It's a dimer, and it has to fold and form a dimer. It should ordinarily here be in the peroxisome, shown here inside of liver cells and to some extent other cells in our body, but it's mostly important for hepatic function. And it's targeted that way. It's sort of the default pathway for a lot of proteins to go to the peroxisome, whereas to go to the mitochondrion, there has to be a specific mitochondrial targeting sequence. And what happens in specific mutations in type 1 PH, the protein does not fold correctly, and it leaves a piece of the protein sticking out that can masquerade as a mitochondrial targeting sequence. And this protein actually then gets transported into mitochondria, where it can function potentially, but that's not where it's supposed to be, and that's not where those other metabolites are being made, which is over here in the peroxisome. So these people get hyperoxaluria. It turns out that pyridoxine is a cofactor for AGT protein, and if you give large doses of pyridoxine or vitamin B6, it helps the protein fold better, and then it ends up targeting to the peroxisome. So in particular, patients that have 2 of these G170R mutations respond very well to this pyridoxine. And this is work that we did here at Mayo a number of years ago, showing that this very common mutation, the G170R mutation, if you have 2 copies of the allele, you are going to be completely responsive. If you are, and this is like on the dark bars are people on pyridoxine, the white bars not on pyridoxine. So if you have 2 copies of this mutation, pyridoxine is fully effective. 1 copy, it's partially effective, and no copies, you're unresponsive to pyridoxine. So if you especially have a patient that is, say, on dialysis, you can't really do these kind of studies testing whether or not they will respond or not respond. The genotype can help you understand which patients you should definitely have on pyridoxine with type 1. There are some other genotypes that will respond to pyridoxine. So despite the genotype, we would always do a therapeutic trial of pyridoxine in the range of 5 to 10 milligrams per day. That's a pretty large dose. So typically you can get pills, say, that are 100 milligrams. So they're going to have to take 7 or 8 of those a day to get enough. But it is very cheap, fortunately. And it doesn't have to be divided up. You just give it once a day. And typically, if they're going to respond, they should within a month or 2. This is showing the different genotypes. This was some older data about 5 years ago when we looked. You can find all sorts of mutations. So there can be truncating mutations, non-truncating, missense. In general, for PH type 3, the genotypes are a little less variable. That's shown down there on the bottom right. That 2 mutations in particular, at this point in time at least, accounted for about 70% of the PH3 mutations. And it's much more diverse for PH1 and PH2. As far as genotype and outcome, this G170R, which again is about 1/3 of PH cases, if you're homozygous for that and you are pyridoxine responsive, you do tend to do better. So this again is showing renal survival versus age. And the red bar are the people that have 2 copies of this pyridoxine responsive mutation, perhaps because these patients are getting pyridoxine as part of this, but we also have noticed that their urine oxalate tends to be a little bit lower than the other type 1 PH patients, so I think that's another factor that favors that. If they're homozygous for other mutations that have been described to be mistargeting to the mitochondria, that may be a little bit protective. They do better, but it's not as if they're prevented from going on to renal failure. And it's not clear if this relates to not getting the pyridoxine early enough or compliance with it, but it is at least protective to some extent. Whereas if you have other mistargeting mutations, it doesn't seem to do quite as well. And then if you have no mistargeting mutation in blue there, those do the worst. So in this case, there is a certain genotype-phenotype correlation. And if we look out in the population as far as carrier frequencies, this is really getting at what we did here. This is work with Katarina Hopp and Peter Harris. Looked at all the known mutations for PH type 1 and then looked at the public databases and looked for the frequency mutations out there. And for PH type 1, we predict that the prevalence overall should be about 1 in 150,000, and this is consistent with other data that's out there. For PH2, maybe a little less, 1 in 300,000. But then for PH3, really seems like there's underdiagnosis of this because it should be as common as PH type 1, about 1 in 130,000. And there's not really any racial differences between European Americans versus African Americans, except for PH3 seems to be a good bit rarer in African Americans today. And that may have to do with the fact that there are some specific mutations that we see that account for quite a bit of the PH3 population. Well, one of the things that we observe in primary hyperoxaluria is that kidney function can really go from pretty normal to end stage quite quickly. And this has been, it's something if you see these sort of patients, you appreciate empirically, but we've been trying to do a little more quantitative assessment of this, in particular to understand how one might look at loss of kidney function in a clinical study and slope of kidney function and how that might or might not work for this disease. And what I was showing in this analysis, we took all the patients and looked at them by the first date that they entered a given chronic kidney disease stage. So CKD2 is when you get to below 75, CKD3A 60, CKD3B EGFR less than 30, and then 4 is, or this 3B is less than 45, and then this is less than 30, CKD4. And you can see even in the CKD2s that the patients start out at pretty good GFRs, all of them, because that's by definition how this graph started off on the left. But there are a lot of patients that just kind of fall off at some point, that they go from pretty good GFRs down to 0 and presumably started on dialysis. And as we go these stages, you see that people drop off much earlier in general than not. And once you get to CKD4, so when they're less than 30, typically it's pretty quick when they go on to end-stage kidney failure. The quantitative way we've looked at it is the actual loss of GFR slope in these different CKD stages, and its overall median, at least, is fairly low in the CKD2 group, and it's similar in the 3A group, but then when we get to 3B, the slope is suddenly -4 per year, and then in this 4, it's -10 per year. And so this is absolute. The percentages are even a little more dramatic. So it does really suggest that using slope of GFR in clinical studies for PH is probably going to be more complicated than for some of the other forms of chronic kidney disease where that has actually worked pretty well. Once we get down to especially the 3B, that these are the people that are likely to progress pretty quickly, and you really do need to follow them pretty closely at that point and be thinking about alternative therapies or if they're going to need transplantation or those sort of considerations. Well, the key parameter again is nephrocalcinosis. It's a specific kind. It's different than what you might see in like calcium phosphate stone formers or renal tubular acidosis. It's a corticomedullary nephrocalcinosis, and if you do a kidney biopsy, you're going to see calcium oxalate crystals in the kidney tissue itself. And why might that be? Well, this is work and presenting work based on Elaine Worcester and Fred Coe at the University of Chicago. And the idea here is that oxalate is freely filtered in the glomerulus, and then some can be secreted in the proximal tubule as well. But really, it's thought that nothing really happens to oxalate in the kidney after that part of the kidney, that through the thin limb, thick limb collecting duct, that there's no net secretion or reabsorption of oxalate. So if you take the urinary oxalate excretion, and then if you know how much fluid's been removed between this point and the end of the kidney, you can predict what the concentration of oxalate should be at the end of S3 of the proximal tubule. And it is known, there are estimates, and it's typically 0.6 to 0.7 is this R value, so that about 30% of the water has been removed by the end of the proximal tubule. So you can do this calculation and predict then, we know what the calcium should be as well. Calcium is pretty constant between people, and so we can know what the ultrafiltrable calcium should be, and do the calculations and sort of predict what the relative saturation of calcium oxalate would be at that part of the kidney. And you do this sort of exercise in patients with pH type 1, and it turns out that most, not all, are oversaturated at this part of the kidney, whereas in normal individuals, this is data from our clinic looking at various kinds of patients and controls, almost never do you see oversaturation at this part of the kidney. pH type 2, they often are oversaturated, pH 3 to some extent, but not as much as the other two. Gastric bypass, which is one of the common causes of enteric hyperoxaluria, a few patients cross that threshold, but in general not. And then your regular kidney stone patients, the vast majority would not do that as well. So really that's the thought, why you get nephrocalcinosis at this part of the kidney, that really it's this oversaturation. The other point here is that this number is also going to be very much influenced by what your GFR is. And the easy way to think about this is as your GFR goes down, you have less nephrons, and that same amount of oxalates being excreted through fewer nephrons. And so this value tends to go up much faster as GFR goes down. And that's probably explaining our observation that when you get to this critical level of GFR that you tend to spiral down, because the urine oxalate excretion is going to stay high throughout. The liver is going to keep producing it at a certain rate, and that's going to lead to problems as you get below these critical levels of CKD. Plasma oxalate, I mentioned, is a very nice biomarker for us in this particular disease. And this is some data, so just cross-sectional data looking at eGFR on the bottom here versus plasma oxalate. And in general, your plasma oxalate tends to run pretty normal, and this is all pH 1 patients. Pretty normal across the spectrum here until GFR start to get below 60. And then there seems to be this abrupt upswing. And in these patients then with CKD stage 3A, 3B or lower, plasma oxalate suddenly becomes a very useful parameter. Number one, it's important therapeutically that as plasma oxalate gets over 20, we know your risk of oxalosis goes up. When you see somebody with an eGFR 45 and a plasma oxalate of 15 or 20, that really is a significant observation and strongly suggests primary hyperoxaluria. And this is just showing that kind of interplay between estimated GFR or kidney function and plasma oxalate. This is cross-sectional data from the Mayo Renal lab. And we have plasma oxalate is most commonly tested in these PH patients, which is shown in blue, but then we also do have a lot of enteric hyperoxaluria patients shown in yellow. And then regular stone patients, occasionally people will be screening for a disease, checking plasma oxalate in that group. And in general, in the PH population, as we saw in that last graph, the plasma oxalate goes way up as your GFR goes down. It does the same thing in EH, but it's shifted over quite a bit and really never crosses this critical threshold of 20 for the most part in EH, but it does quite commonly in PH once they get below certain GFRs. And then in the stone patients, you know, again, your plasma oxalate tends to go up, but not as dramatically as GFR goes down. And in regular patients without any pH that are on dialysis, you can see plasma oxalates of 10 to 20, and that doesn't necessarily mean there's anything going on. Probably explains why we don't see oxalosis in EH really at all, or in the regular population on dialysis, but we definitely do in primary hyperoxaluria. And then also interpreting plasma oxalate, really having a figure like this in mind is very helpful when we draw these and we're trying to say, yes, no, do we suspect pH? You really have to take into account what their eGFR is. So much like we've seen with urine oxalate, and given the fact that we know there is this interplay between plasma oxalate and urine oxalate, it's also a prognostic marker. So in stage 1, here we took our registry data, looked at pH patients and divided plasma oxalate into quartiles, much like we did with the urine oxalate. And certainly when we get below CKD stage 2, if you're in the highest quartile of plasma oxalate, you are at higher risk of progression to end-stage kidney disease eventually, and for stage 3, and then especially stage 3B. So this is the group between 30 and 45. So plasma oxalate prognostic marker of a worse outcome down the road in this particular disease. And this is showing what happens to plasma oxalate on dialysis. So it's high, and again, the scale here, so this is the average here of this population. So these are patients that had been seen at Mayo, and we had values for their plasma oxalate multiple over time that they had started dialysis. And the mean here is right around 75 or so. So that's a very high number. These are pre-dialysis plasma oxalates. And at that level, likely this is depositing between each dialysis session out in the tissues. It's not as if it goes up higher over time, and that's probably, again, because this oxalate, when it gets above a certain threshold, you cross the supersaturation out in the body, and it's depositing in bones and vessels and all sorts of bad places over time. And that's another reason why we really don't want to keep these people on dialysis very long. They can develop oxalosis, and this is typically over a year. So patients with PH, often not recognized, dialyzed in a routine 3 times a week kind of way. It starts to deposit in various tissues, and this can include bone, vessels, muscle, nerves, retina, and skin. And shown here, this is an eye exam, and this patient had pretty bad oxalate deposits in the eyes, which are these little yellow dots out here away from the nerve. This was a younger patient that developed a pathologic fracture. Her bones actually are increased density, but more fragile. And then this is the skin finding. So it can look a lot like calciphylaxis, but if you do a biopsy of it, you will see these birefringent crystals. That is not what you would see in calciphylaxis. Calcium phosphate would not fluoresce like this. And we've tried to quantify this. When do people get these? And we've, again, divided into these 6 different systems. And on these graphs, no oxalosis is the lighter orange, and then the dark brown is with oxalosis. So before dialysis, some patients develop some oxalosis findings even before they're started on dialysis. But after a year, this starts to go up, and then after 2 years, and by 4 or 5 years, most patients, and the numbers here are lower because either they've gotten transplanted or they've died while on dialysis. So the total numbers are less, but the percentage that would have any system involved in oxalosis becomes almost entirely by the time you get out to 4 or 5 years. And this is just to give you a sense of what happens to oxalate on patients when they're on dialysis. And this is normalized because we were pooling data from a lot of patients and just trying to express this on one single graph. But the oxalate starts out at a high level, and it drops by at least 50% on average by the end of the first hour, and then continues to drop out to hour 2 and 3 and 4. And really, at that point, you're not removing. Down here is shown the dialysate oxalate, and then it really, you start to have diminishing returns. If we stretch out the dialysis beyond 3 or 4 hours, you don't really get a lot more oxalate removed. But what does happen once you stop the dialysis, and if we continued measuring or kept the person there and looked, it's going to pop back up to almost the previous pre-dialysis number within 3 or 4 hours of the session. So that really the way to get more removal in these patients is to dialyze them more often rather than longer. And that's why we typically, based on their urine output and what their pre-dialysis oxalates will do, we'll start ramping up their dialysis to 4, 5, 6 times per week for the period of time that they need to stay on dialysis. But again, even doing that, they're going to get into trouble eventually. So that really, we want them to go on to get something more definitive. And to date, that's been a kidney liver transplant. And this slide here is showing a represented patient that did go on to kidney and liver transplantation. So the liver part is to replace the defective enzyme, and then the kidney to give them a functioning kidney. There have been different strategies with this. Some places would prefer to do the liver and then hopefully dialyze them a lot and get the oxalates down and then do the kidney. And I think the opinions are mixed about which way to do it, but I think most commonly now it's being done as a combined kidney and liver at the same time. But it's really important to make sure your patient is in good condition going into this. So we do tend to dialyze them quite aggressively and hope to have their pre-dialysis plasma oxalate level as low as possible. And this period right after the transplant is really the period of greatest risk. So in this particular individual, he was being dialyzed very aggressively. So his pre-dialysis plasma oxalates were actually pretty good here, only 20 to 25, which is really excellent for this particular patient group. And then he got his transplant here, but then had some allograft dysfunction in the kidney, and the plasma oxalate starts to go up. So we really monitor the plasma oxalates very closely on a daily basis and keep dialyzing them until we know that this plasma oxalate is less than 20 for sure, and we really want it less than 10 to not put that new kidney allograft at risk for loss. And really, again, how long you're going to have to do this depends on how much systemic oxalate deposition there is in a given patient, as well as how good their kidney allograft works. If there's primary graft dysfunction, it's going to be more problematic. It can really take a while, especially depending on how long they've been on dialysis and how much oxalate's out in the tissues for this to get mobilized. This guy, and again, his was not so bad, his plasma oxalates before, so it wasn't surprising that he came down pretty quickly. But when we've looked at our whole population here, this is urine oxalate over time after a kidney liver transplant. Many of these patients will take, and this is months, so really to come down to normal here, which is 0.45, sometimes takes 6 or 7 or 8 months before they'll normalize, and that's presumably while they're mobilizing all this oxalate out in the tissues. So what are our treatment strategies? Well, number one is high fluid intake to the extent we can keep their urine dilute and their nephron collecting duct fluid dilute. They're going to have less risk for calcium oxalate crystallization. So that's always been the mainstay of therapy for these patients. Crystallization inhibitors is the next strategy. So we've traditionally used neutral phosphorus, but potassium citrate also works similarly. In the PH1 patients that are responsive to pyridoxine, that's a key part of their regimen. And then if they do get kidney failure, they need intensive dialysis guided by their plasma oxalate levels, and then hopefully can go on, at least traditionally, the liver and kidney transplantation has been the definitive treatment. Fortunately, we do have some solutions actually not only on the horizon. There's one for type 1 that's out there now, and it's the Alnylam lumasiran siRNA strategy. And shown here on the right is it's basically blocking glycolate oxidase. So it's not directly intervening with the enzyme that's mutated here, AGXT, but it's blocking production of glyoxylate from glycolate, and then that in turn can no longer go on to make oxalate. And so it's a sort of substrate inhibition, if you like. When people receive this siRNA, their glycolate levels will go up, and that's been observed in the studies, but there's no known toxicity to having high amounts of glycolate. In particular, it doesn't cause calcium glycolate kidney stones. And so there was a lot of basic science that had been done to suggest this might work for type 1 PH. And indeed, the studies looked and are very promising with this. This was their phase 2 study, just showing there was a fairly durable effect here, that patients in phase 2, they went on this for open label extension out to 12 months. And for the most part, the urine oxalate levels were normal or close to normal in the majority of those patients that were receiving this. It's administered as a subcutaneous injection. And for this, the way that Alnylam is doing it, it's every 3 months. So it's really not that often. So they get one of these every 3 months. It is targeted directly to the liver and is blocking GO production at the messenger RNA level. The double-blind, their phase 3 study was completed late in 2019, and turned out that this was quite positive. That their key endpoint was drop in urinary oxalate, and was highly significant that it went down over the 6 months that patients were receiving this siRNA treatment. And there was, in this study, no serious events or adverse events. It was well tolerated. Injection site reactions was really the only common thing, and these were none serious. They were transient and resolved. And this has been FDA approved now in early December. So this is actually out there, and potential treatment, but it's again only for PH type 1. As you may recall from this slide with the hepatic pathways, glyoxylate transition to oxalate mediated by LDH is key in both type 1 and type 2. And we also think in type 3 that it's actually mediated by high glyoxylate because of this substrate inhibition with 4-hydroxyoxyglutarate. And so in theory, if you can block LDH, that should also reduce oxalate production, and it might actually work for all 3 types of primary hyperoxaluria. There is a specific liver enzyme, so it's an LDH isoform A that's in the liver and not in your other tissues. So if you can target this directly to the liver and block this isoform, you could potentially treat PH. The siRNA that has been developed by Dicerna targets this A form of LDH, and it's going only to the liver. So they have also shown some phase 1/2 data. This was at ASN again a year ago. They showed some similar data at the most recent ASN a month or two ago, showing that, and this is just in patients with type 1 and type 2 PH, that there is similar reduction if we go out over time, that urine oxalate seems to be normalizing in a high percentage of patients. They're dosing it a little differently. They're giving it every month as opposed to every 3 months subcutaneously. Their phase 3 studies for type 1 and type 2 PH are ongoing as we speak. Probably there's going to be some results from that in the next year or so. So I think that especially for our type 2 and type 3 patients, there may be some exciting news down the road for them as well for very novel therapies. So in conclusion, primary hyperoxaluria can be caused by autosomal recessive mutations to at least 3 different hepatic enzymes. Frequent kidney stones occur in all 3 types. Chronic renal failure is common in type 1. It's rare in type 3, but intermediate in type 2. PH patients are at high risk of oxalosis once chronic renal failure ensues. Thus, these patients require frequent dialysis and careful monitoring of their plasma oxalate levels until definitive treatment can occur. Traditional treatments for PH include hyperhydration, crystallization inhibitors such as citrate and neutral phosphorus. A subset of the type 1 PH patients will respond to pharmacologic doses of pyridoxine or vitamin B6, 5 to 10 milligrams per kilogram per day. One promising siRNA therapy that targets hepatic glycolate oxidase was recently approved by the FDA for type 1 PH, and additional therapies are under evaluation for other hepatic pathways that could potentially be beneficial for all forms of primary hyperoxaluria. Thanks so much. I really enjoyed being able to give this presentation, and I'll throw it back to you.